One lecture has got amazing pictures. You're gonna love them. If you haven't had breakfast, or maybe if you have had breakfast, you might be a little nauseous later as we go through. I'll try to warn you before they're totally gross. Okay, congenital disorders. There are only a couple that we need to talk about. You'll notice on your topic list that deafness is on there as well, but it's more like the deafness you covered in ears. So remember Weber-Renee, is it a sensory neural hearing loss? Is it a conductive hearing loss? That's basically all you need for the exam, okay? So I'm not going to cover deafness here. Choanal atresia. This is something you will notice immediately upon birth. This is not something that a 3-year-old will come into your clinic later and you suddenly discover they have this, because the baby will instantly turn blue once they're born. This is a problem with development of the opening from your nose to your oropharynx. So you don't have that opening. Instead, they get this bony part that develops across it. So they physically cannot breathe through their nose. Like there's no passageway there at all. And unfortunately, newborns are obligate nasal breathers. They don't have that reflex where they know how to breathe through their mouth. If you hold their nose, they don't know to breathe through their mouth. And so they will immediately turn blue because they're not breathing. You will try to pass a little catheter back through their nasal passage. It'll get stuck. It won't go any farther. They instantly get intubated and they go to surgery. This is something you fix immediately. And it can be fixed. You just have to go back and remove that little part. So surgery is the definitive treatment. This is what they look like. And that one is in surgery. Isn't she a cutie patootie? There's no particular disorder that this is more commonly found in, although most kids who have this tend to have other anomalies, like their malformed heads or mal-shaped faces in some way. Although it doesn't particularly go with one disorder that you can say is more commonly found with this. Okay, cleft palate and lip. This is something you'll see quite commonly, although in the United States we tend to fix them pretty early on. In developing countries they don't always get fixed, and some people live their whole lives with these. It can come in lots of different forms. It can just be a unilateral lip cleft. It could be bilateral lip. It could be lip plus palate. It could be palate only with no lip. So it comes in lots of different variations. This is what they look like. We usually don't know what causes it. We suspect anything that can cause any kind of birth defect. So genetics, drugs, viruses, toxins that the mother was exposed to when she was pregnant. So that being said, that we don't know any way to prevent this from happening. You know, like with neural tube defects, we say make sure you take plenty of folic acid in prenatal vitamins to prevent that. There's nothing we can do to say how to prevent cleft lips. It just happens. So complications, the first one the parent's going to notice and is going to freak out about is the appearance. I mean, obviously your baby comes out, you're so excited to have a brand new baby, and then they've got this thing going on. It's pretty dramatic and pretty heartbreaking. But for the baby, obviously they don't care what they look like. For the baby, the big problem for them is feeding, because they can't get suction on a nipple, and then with a cleft palate, the milk will go up and come out their nose, because it can't go down, because they don't have that nice palate to help everything go down where it's supposed to go. So because they can't eat very well, they don't gain weight very well, they don't grow very well. They get recurrent ear infections because they don't have that palate to keep all the fluid from going into the eustachian tube openings up in their nose. And they usually have speech difficulties. So treatment is surgery. That's the way we treat them. And usually we do it as early as we possibly can. Sometimes as little as 6 weeks old. Tiny little babies, if it's small enough, we get them in there, we get it treated, and it's usually fantastic. They usually will need speech therapy. Sometimes they will use a little prosthetic palate device, which we're going to show on the next slide, and it helps them with feeding until they can have surgery. These little devices are called a nasoalveolar molding device, or NAM, is how you'll hear it referred to. And this is a mold that's made by a pediatric orthodontist, and what it's supposed to do is to gently, passively mold the palate as the baby is growing until they get to surgery. So most often this is used with babies who have a really large cleft palate. And the surgery, they can't do it in one surgery. They're going to have to do multiple surgeries in order to get it to close. They will try a NAM first until the baby gets a little bit bigger, and then they'll go in and do the surgery. The little nasal stents on the front are to help to straighten the nose up, because you will notice a lot of babies who have cleft lip, one side of the nostril will be kind of flattened down, and this kind of helps hold it up and mold the nostril up. Look at that little fella, he's excited. That middle picture, not so much. not look happy. Although supposedly once a baby gets used to it, it doesn't hurt and it doesn't bother them, and they can feed better, so that helps. I can't even imagine trying to get a baby to keep that thing in. Okay, so those are the only congenital things you need to know. All right, so let's talk about benign neoplasms, things that aren't cancerous. Papillomatosis, this is basically warts inside your oropharynx or your mouth. From the same virus that causes warts anywhere else on your body, HPV. These aren't technically considered a sexually transmitted disease, although I guess it could be if it was oral sex and that's how you got them later on as an adult. But for the most part, we don't consider them a sexually transmitted disease. We see them a lot in children and even babies, and we think they probably get it whenever they come out of the birth canal. So if a mother is HPV positive around the cervix, she has infection there, then she can transfer it to the baby when they're born. These can get big enough that they can actually block the airway, causing difficulty breathing. So symptoms, your patient will come in, if they're grown up, they'll come in and they'll say, my voice is just really hoarse. Or sometimes they can hear themselves breathing, especially when they lay down at night. They can kind of hear a stridor, almost kind of a raspy, they kind of hear that noise. In little kids, the parent will either notice that their voice seems rough or hoarse, or the parent will hear that weird noise whenever the baby's breathing at night. You have to look at them. So indirect laryngoscopy is what Jamie was talking about. You grab the tongue, you have your light source on, and then you have the mirror and you kind of angle it. Direct laryngoscopy is the flexible nasal laryngoscope she showed you, and those are really fun to do. At OU, we had one in the Green Clinic, Family Medicine Clinic, and so I could always steal it when we did ENT, and then I would look at one of the students' vocal cords with it, and we could see it. It was really cool. So, sorry, you guys don't get to do that. Treatment, tumors tend to return. So usually we will surgically remove these, but often we have to do it more than once because they tend to come back over and over again, unfortunately. Very rarely do these become squamous cell carcinoma, but if they ever do, then there's a poor prognosis. All right, so these are what they look like on the vocal cords. Can you kind of get, so these are vocal cords. I know they look like other anatomy, which was the first thing I thought when I started in ORL. They had a big picture of these on the wall, and I was like, what clinic am I in? What's happening here? But these are what vocal cords look like. Can you kind of get an idea of how these aren't nice and smooth like a polyp? They're kind of lumpy and they look granular. So that's what you'll look for with any kind of HPV infection. Any kind of warty growth will look like that. Just kind of warty looking. They're not painful, but you can definitely imagine how that would cause you to have a hoarse voice because your vocal cords can't come together and touch each other to vibrate and make the sound. So that's where you get the hoarse voice going on. An inverted papilloma is basically the same thing except it's in your nose. So whenever it's in your nose, we call it an inverted papilloma. Often misdiagnosed as a nasal polyp. For one, it's really hard to see it. You just see something weird hanging down in the nasal cavity and you go, oh, it looks like a polyp. But also they can be almost kind of smooth looking, not quite as warty as the other, although if you look close they are. Often contain HPV, so anytime you think papilloma in any form, think HPV. That's probably its etiology. But we have found that some of these also have Epstein-Barr virus. What else does Epstein-Barr virus more commonly lead to? Oh no, good. Yeah, you guys got the question right. Look at that. You're halfway there. Most commonly, the patient will come in without any other symptoms other than, I just keep getting this nose bleed on this one side. My nose keeps bleeding, I don't know why. Or they may have a lot of nasal congestion. They just can't breathe out of that side. About 10-50% can become squamous cells, so we have to watch these. And these can actually cause bony destruction, so they can eat into the sinus. You have to be careful with those. Surgery, same thing. So this is what they look like. They're not nearly as smooth as that polyp picture you saw on Jamie's lecture yesterday. They're just kind of warty and, you know, warty. Okay, so let's talk about salivary gland enlargements and masses. There are some benign ones that can happen. One of the most common things to happen if you see bilateral salivary gland enlargement, you don't feel a mass, there's nothing discrete that you can palpate in there, they're just kind of big on both sides, then you want to think Sjogren's syndrome, because that's a big thing that can happen with them, along with dry mouth, dry eye, everything else that happens to them. The tricky thing about salivary glands and anything that happens in them is that typically the benign and the malignant growths are not painful, which is really tricksy of them to do. Because just about anywhere else in the body, if you have a benign growth, then it usually is painful, right? We always think, oh, if it doesn't hurt, then it could be cancer, right? If it's a tumor that doesn't hurt, usually that means cancer, because they don't hurt until they push on something else that begins to hurt. But in the parotid glands, that's not the case. Both of them tend to grow about the same rate, whether it's malignant or benign. They both grow pretty slow. Neither one of them hurt. They're kind of buggers that way. You gotta watch them. In general, bilateral suggests benign process, but again, not always the case just with the parotid gland. Okay, so how am I going to figure out? Well, crap, it could be either. They present the same way. I got to get a fine needle biopsy. And all that is you take a needle on the end of a syringe, you pull the syringe a little bit to get some suction after you've already numbed the area with some lidocaine, and then you literally just poke this needle in a bunch of times. You will get some cells that come up into the needle itself, and then you go to a slide, squirt it all out on the slide, and they take it and look at it in pathology. That's a fine needle biopsy. And then we need a CT scan, and then surgery is how you take care of it. So, the most common benign salivary tumor is a pleomorphic adenoma, most commonly in the salivary glands. Okay, pleomorphic adenoma is one you'll hear over and over again. If that's one of the question options, you should probably pick that. That's probably what it is. More common in females, again, not painful, even though it is a benign process. Parotidectomy is a treatment of choice. Can you tell where the tumor is in this picture? Okay. Probably this. Just look at both sides. They should look about the same. See which one is not like the other thing. And that's what it is. They can get pretty impressive and pretty big. So treatment is to remove it. The tricky thing about pleomorphic adenomas, and we saw a lot of these in the ORL thing, the patient would come in, we do the fine needle, they'd come back and we'd say, okay, it's not malignant, it's not a cancer, it's a benign thing. And they're like, oh, so it won't kill me. Well, technically no, it probably won't kill you. Well, then I don't want surgery, I don't want to take it out. But the tricky part is there's a very fine window of opportunity when the tumor is small enough that we can probably get it out without killing your facial nerve. If it gets too big, then we're going to have to sacrifice your facial nerve, and this side of your face is going to be paralyzed forever. So it's really tricky. You have to catch it in the right window of opportunity. And these can get big enough that they will compress the facial nerve and they get facial paralysis anyway. Borderline tumor is another one you will hear about. Again, it's just a benign tumor. So if you ever hear Borderline, it's benign. It's treated exactly the same as pleomorphic. Okay, vocal cord polyps and nodules. The nice thing about these is that it doesn't really matter which one it is, you treat it the same way, and they're both caused basically the same way. Phototrauma is the way most of them are caused. That means you talk too much at a high voice. You yell too much. Pretty sure my kid's going to have phonotrauma at some point. Oh man, I wish you'd get a nodule that you couldn't talk. Sweet. Nodules, so some differences between polyps and nodules. Nodules usually are bilateral, and it's usually caused by phonotrauma, where the vocal cords come together all the time, and you've built up basically a callus, is what they are, a little callus from too much phonotrauma. So there'll be one on either side where they hit. Whereas polyps, more likely, are just one, and they stick out a little bit farther, they're a little bit bigger, and they're usually secondary to an acute trauma, like you damaged that vocal cord and it kind of built this little polyp over the top of it to protect it. Most often observed in women, age 20 to 50. I don't know why that is. Can't imagine. Also found commonly in little children, especially boys who like to scream at the top of their lungs. I'm pretty sure Kunle's child got some phonotrauma. The white coats everybody. He's so cute. Okay, so this is what they look like. The polyp is the one over on the left, and the nodule is the one over on the right. So polyp. And polyps also can be pedunculated, which means they hang off of a little stalk. So they'll have a little stalk and then the polyp will be up here on top. And then the nodules are smaller, a little bit firmer. The patient will come in saying they have a hoarse voice. The patients we saw the most in ORL with this condition were vocal majors. We saw a lot from here, actually, who would come in and say, I just can't, my voice isn't as strong as it used to be. I can't hit those high notes. I can't hold the note as long as I used to. My voice isn't as strong, is what they would normally say. And we'd go, oh. And then we would treat them, of course. So you have to correct the underlying cause. So if the underlying cause is phonotrauma, how do you correct that?
Stop screaming.
Stop screaming. Don't talk. Voice rest. And for those patients who really were dependent on their voice, like they were vocal majors, we would say literally 0 talking at all for at least 2 to 6 weeks, usually 6 weeks. We did have one patient, one young lady, who she had to wait until the semester ended, and then she didn't talk for 4 weeks straight. She carried around a whiteboard, she wrote things down, did not say a word to anybody for 4 weeks. And she came back in 4 weeks, the nodules were completely gone. Voice was back to normal. So it's very hard. Now, one thing I will tell you is tell your patients that whispering is even worse than talking, because they'll say, okay, I won't talk, but I want to whisper. And whenever you whisper, that actually puts more strain on your vocal cords than just talking normally. So tell them, no, none of that. If we can't heal it that way and get it to go away, last resort is surgery. And you can go in and cauterize them or destroy them with a laser, but it's really tricky because unfortunately you can cause scarring, which will be permanent. Whereas the nodule we could probably get to go away if you honestly did voice rest for 6 weeks. If we do surgery and you get any kind of scarring, that's permanent, we can't fix it. So it would be leukoplakia. I think Jamie already talked about that. We talked about that, didn't we? Didn't she talk about leukoplakia? No, she didn't. We took that out. Okay, so leukoplakia, white stuff in the mouth. So these are little patches of white stuff in the mouth. Oftentimes we don't know exactly how it got there, and usually the patient doesn't know how long it's been there. The most times I've seen this in clinic is a patient went to their dentist to get their teeth cleaned, and the dentist noticed this and said, you better go see your doctor and get this checked out. So this is a change in the mucosa due to lots of different things. Tobacco use is a really common one. We blame everything on tobacco, but because it usually is the cause of everything. So tobacco use, alcohol consumption, chronic irritation of something, some vitamin deficiency, some endocrine disorders. Often we don't know exactly what the cause is, we just know it's there. And this is what it will look like. Just this patch of whiteness around there. Yes, ma'am?
What's the difference with this and thrush? Is thrush just like a...
Excellent question. So, but how will you know when they come in, right? They're both white, they're both on the tongue or different parts of the body. The differences will be with leukoplakia, it's not painful. So whereas thrush, your mouth will be kind of burning and it will be uncomfortable and painful. With leukoplakia, it doesn't wipe off. You can't rub it off, you can't scrape it off with a tongue blade. With yeast or thrush, you can. If you scrape it, it will kind of come off a little bit and then it will be red underneath. So that'll be the big way you can tell the difference between the two. And that's something to always look for any exam question from now on out. Obviously look for it when you're actually practicing, but for any exam now or when you take the pants, it will always say white spot in the mouth that either can or cannot be rubbed off. And that's the key thing to look for. It'll tell you what it is. Treatment, surgery, or cryotherapy to remove it. Usually they'll just do cryotherapy or do a little bit of laser surgery to burn it off. But you need to do something about it because it can be precancerous. Anytime you see leukoplakia, think precancer, and I need to look into this. Yes, sir.
Quick question. Yesterday we were taught that thrush you can't wipe off, and that's how you differentiate between thrush and milk mouth.
She said you could, it's just painful.
You can get all of it off though, and it would be red underneath.
She does.
Oh, okay.
You can just simply wipe off.
Yeah, she just said it was like, if it was milk, you could just simply get it off.
It is very confusing. I agree. But with Candida, you can scrape it off.
Okay.
Probably not all of it off, but it will be painful to the patient and it'll be kind of red underneath. The leukoplakia, it won't hurt at all. So that should be another thing, a key, any kind of test question, it'll say it's not painful. Thank you for bringing up that question. I'm sure other people thought it too. Okay, we talked about that. So here's another picture of leukoplakia. Oftentimes they're not this dramatic. I wish they were all this dramatic. That'd be great. Then I'd never miss one. Notice where this is on the patient. Remember Dr. Bass said that's where most of the cancers are, the lateral posterior aspect of the tongue. That's where you honestly will see a lot of this stuff. And this patient probably didn't even know it was there. It doesn't hurt. He never looks at that part of his tongue.
Those images were both beneath the tongue. Is that, well, that's on the side or beneath, and then thrush would normally be on the top of the tongue. Is that pretty consistent?
Generally, in general it is, but I wouldn't count on that as a way to differentiate them, but yeah. Okay, erythroplakia is a cousin of leukoplakia, a distant cousin, once removed. This is a premalignant condition, and you will see it a lot in the middle of leukoplakia. So you notice this kind of just general leukoplakia, and this is more what leukoplakia will look like. It won't be nearly as dramatic. You just kind of see these little white pop spots, and you think, well, maybe that's just how they always look. How would I know if that's normal for them? On this one side of the tongue.
Look at the other
On the
side.
other? Yeah, look at the other side of the tongue and go, oh, wait, it's not over there. Okay, so it probably is different. So generally they'll have a little bit of whiteness, leukoplakia, and then they'll just have these little bitty spots of redness, erythroplakia. This is a really bad actor. You gotta notice this one, and this one has to get a biopsy because its malignant potential is 17 times greater than leukoplakia. Leukoplakia, not so awesome. Erythroplakia, they're like the mob boss in this crime family of cancer. Treatment, excisional biopsy. So we're going to biopsy it, but we're just going to take the whole thing off at the same time when we're biopsying it, because we're not going to mess around with it. Again, under the tongue where they're probably not going to see it. They're not really going to feel it. Okay, oral lichen planus. This is a chronic recurrent inflammatory disease that we really don't know where it comes from. And this is one of those frustrations you'll have when you see patients, because you know the diagnosis based on their clinical history and what it looks like, but you can't tell them exactly how they got it. And they'll say, what? Medicine people are supposed to know everything. So my line when that happens is, I know, you'd think modern medicine would have figured this out by now, but we don't. But I can treat you. So very small potential to turn into squamous cell. This isn't like leukoplakia, although it will look like leukoplakia, it might confuse you. But the patient history will be able to tell you that it's different. Because the patient will come in and say, I have this white spot, and usually it's on both sides. Instead of just one side, like the leukoplakia is, you'll notice it on both. They will say it's painful. It's rough to the touch, and it burns, especially whenever they eat anything spicy or hot or acidic, like orange juice will set them on fire. They can also have lesions other places, like skin, scalp, nails. I've never seen them there, but I have seen it in the mouth. Actually, my mother has this. So every 6 months she'll call me, Shirley, could you call me in some of that lichen planus? That's not really how she talks. That's my impersonation of her. So this is what it looks like. They have what we refer to this kind of lacy pattern. It's white, and can you see how it's kind of, we call it lacy because it has all these different little bare areas in the middle. It's not nice and consistent like leukoplakia. It's just like a solid carpet of stuff. Whereas this has little holes in it, and it's more of a lacy appearance. And we call that Wickham striae. You may hear that term. They don't use it as much anymore. They're trying to get away from dead guy names, but Wickham striae is what that's referred to. Can you appreciate the difference between what this looks like and the leukoplakia looks like? Okay. There's no curative treatment. Recurrence comes back over and over again, whenever, randomly. They might make it a whole year before they have it again. It might be 3 months and they have it again. We never know. But this is the treatment for it. Fluocinolone topical, also called Lidex. I know, I've called it a million times. And it's just a steroid. It's an oral steroid that you can put on it 3 times a day. So we just treat it symptomatically, tell them to take some Tylenol or ibuprofen for the pain. Eat kind of a bland diet for a while, like don't eat anything hot or spicy. Eat fresh fruits and vegetables, because sometimes we suspect, although we don't know for sure, that it could be brought on by not getting enough vitamins in your diet. We don't know exactly which ones cause it, but that's right there. I think that's just what we've decided to tell everybody. Well, I think you need to eat more fruits and vegetables. That's what it is. That's why you've got this. That's why you've got bedhead, because don't smoke and don't drink a lot of alcohol. Aw, dang it. Yes, ma'am.
As far as telling apart leukoplakia versus oral lichen, so is lichen always gonna be on the mucosa, and is leukoplakia always gonna be on the tongue?
No.
No.
Could be anywhere in the mouth.
Both of them can
Both
be
of them
anywhere?
can. Yeah, so I've seen lichen on the buccal mucosa on the side. I've seen it on the side of the tongue. You can get it in the floor of the mouth, just like leukoplakia. So the difference between those two would be that it looks a little bit different. It's not as solid as the leukoplakia. Neither one of them can be rubbed off, of course. But the lichen planus is going to burn. So this really burns a lot. Like when I brush my teeth, oh, it just hurts so bad. The toothpaste gets on it and burns it. Whereas leukoplakia doesn't hurt at all. Candida also hurts, although it can be scraped off if you scrape hard enough. You're going to have like a flow chart. Does it hurt? Yes. No. Does it do? Smokeless tobacco keratosis. This looks a lot like leukoplakia. Honestly, you're going to treat them the same because they are kind of caused by similar issues. This is basically where the skin just becomes pale because they sat their smokeless tobacco in that one spot for years and years and years. This doesn't hurt either, generally. It's just an area where the skin is really pale and doesn't look very healthy. It is precancerous, so you have to be careful. And you should have it looked at and probably get a biopsy. What else does this lovely patient have? Right. So they have some, right, they have some sweet periodontitis down here. You notice they had some gum loss. They've probably got a few caries going on. Okay, any questions about the benign stuff? Thrush, leukoplakia, lichen planus are all kind of confusing. Just try to figure out the one thing that makes it not like the other ones. Either it hurts, or it burns, or it wipes off, or it doesn't. Okay, so let's talk about the really bad actors, the things that can go south. Malignancies. Squamous cell carcinoma. If you are ever in the middle of an exam and it's about head and neck cancer and you have no idea what the answer is, but squamous cell is one of the options, pick it, because it's probably the answer. 9 times out of 10, squamous cell is the cause. 90% of all head and neck cancers are squamous cell. They will look different depending on where they are in the head and neck. They will spread at different rates depending on where they are in the head and neck. So there's not one specific way it will look or how big it will get or metastasizes. It's all different depending on where it is in different parts of your body. One thing to remember about anything in the head and neck, especially if you get a malignancy anywhere in here, you're talking about a really compact area. So if you have even a small, tiny little cancer, but you have to get a 4 millimeter clear margin around it, that's a lot of clean tissue you have to get. So it could be this tiny, but if I have to get this big a margin, then I've lost half my face because of it. So when you see head and neck cancers and the after effects of the surgery, it's pretty dramatic, unfortunately, because lots of things can get in the way of that tiny little tumor. There is some viral etiology to some of them. Oh, again, alcohol and tobacco. All right. Keep in mind that alcohol, when we say alcohol contributes to it, it's not like I have a glass of wine with dinner every night or I occasionally have fun with friends. It's you're drinking a 6-pack of beer every night, 7 days a week. That's the kind of patient who's going to get alcohol, not necessarily induced, but alcohol-caused squamous cell carcinoma. Epstein-Barr can be a problem, and again, HPV, like we talked about before, especially tonsillar cancer. We're seeing a lot more tonsillar cancers that are HPV positive. When I was working in the head and neck clinic, the surgeon there would often ask the patients, they would say, you have tonsillar cancer, it is HPV positive, have you ever had oral sex with someone who has HPV that you know of? Does your wife have HPV? So that was a difficult conversation with a 70-year-old gentleman to have. But, so this particular squamous cell carcinoma, if it's HPV positive, we do consider it an STD type related issue, okay? Not, as opposed to the papillomatosis that we talked about earlier, that's not necessarily. You don't have to have that conversation with your patient or send them to oral. Environmental exposures, again, just like with any cancer, anywhere on the body, we go, well, it could be anything. Anything at all you were ever exposed to. Especially anything that you can sniff up your nose. So whenever we think about things like asbestos or fumes, we think about, oh, you probably get lung cancer from that. But think about where those fumes have to travel before they get to your lung. So they have to come in here, they go all the way through nasopharynx, oropharynx, all the way down. So it can cause a cancer anywhere in that tract. This is an oral squamous cell carcinoma. This one over here is a posterolateral tongue. This doesn't hurt, I'm sure. The patient probably came in because they went to the dentist and they said, you know, something back there, you better go check that out. They may not have even known it was back there. At the very back of your tongue, there's this nice little crevice that it fits down in. You got lots of room back there. So it's hard to feel anything in the back of your tongue. This is a floor of the mouth one. This one doesn't hurt either. Again, nice little crevice. We've got lots of room down there for things to grow before we ever notice they're there. So that's why it's so important to do a thorough oral exam, especially if your patient has any risk factors, like they smoke, they drink lots of alcohol. All right, signs and symptoms. Again, it probably doesn't hurt. Usually they come in, it doesn't hurt. Most of the time they start out as a red lesion inside the mouth, but it can start out as lots of different things, so don't count on that. Can be leukoplakia, a third of them start out as leukoplakia. These are all the places it's common for it. The tongue is a big one, especially the back and lateral side of the tongue, floor of the mouth. The tonsils, we can't really feel back there either, so you can get little things back there. Lymphadenopathy is a big one. Honestly, this is the one that most of my patients came in with, except the ones who had like dramatic things growing off the side of their head. They would come in and say, I've just had this knot right here in my neck. It doesn't hurt at all, but whenever I feel it's just been there for a while, it's kind of hard. And then come to find out, it's a big giant lymph node that's metastasis for your tonsillar cancer. So if you ever have a patient who comes in, a grown patient, who has a non-tender lymphadenopathy unilaterally, then you should suspect tonsillar cancer on that side. It's a really common place to see it. Okay, this is generally what they come in with. What? There's no way I can pick this up. Oh my gosh. They're really not dramatic at all. So this one just barely, some really light leukoplakia, and then this little red spot here is the squamous cell. Eee. So no pressure or anything to catch these little buggers. And then just this nice little bit red spot down here, some squamous cell carcinoma. Treatment, surgery. So like I said, we have to get a clean border around it. Sometimes that can be pretty dramatic and take a lot of tissue with it, depending on where it is. Then they usually get radiation and chemotherapy. And they have all kinds of great new immunotherapy, gene therapy stuff in place of chemotherapy that they're coming out with. So those are on the horizon. So these are some other ones. I showed you these after the other ones so that you'd be like, oh, well, I know I could catch this one at least. Surely I would notice something was wrong here. Notice this one. This is a squamous cell carcinoma of the lower lip. You will likely run into this, especially out in rural Oklahoma. Your 70-year-old farmer rancher who spends all days out in the sun wears a hat for his head, but it doesn't cover his lip, and so he doesn't get the shade over his lip, and that's where it will happen. This is the back of the tongue. That was pretty nasty looking. This little guy here. This is basically, they've grown a second tongue on the side of their one tongue. So this is the crease, upper lip here, lower lip here. They pulled the tongue out and they just put a gauze behind there. So this is a tumor off the side of the tongue. And we have actually seen patients in ORL who came in and they were like, I don't really know how long it's been there. It doesn't really bother me. My dentist noticed it and thought I should come in. I'm glad you did. We gotta get rid of that bugger. Okay, any questions over squamous cell? Yes, ma'am.
So this is going way back, but in anatomy, when we kind of covered some of the carcinomas of the head, and he called squamous cell generally benign. Is this always considered malignant, and I could be remembering that wrong if anybody remembers that, but I remember because there was the guy with a big, huge hole in the side of his head, but it said squamous cell is benign, and I remember being very confused by that.
I don't know.
Basal
Basal
cell.
cell.
Oh,
benign.
just kidding.
Basal cell, okay. That would make more sense, yes. But I'm glad you brought that up, yes. So basal cell is a benign, although we're not covering it here. Squamous cell is generally malignant. Okay, nasopharyngeal carcinoma. We'll cover this right quick while Larry's gone home with it. This is a rare carcinoma in the United States. Very, very common actually in mainland China. It's the most common cancer in males in China, which I think is just insane, and the third most common in females in China. But where you need to be careful here, although you won't generally see it in the Caucasian population, if you have any patients who are of Chinese descent in the United States, then you need to keep this in the back of your mind if they present this way. So general signs and symptoms are really benign and easy to miss. They will come in and say, I have a chronic middle ear effusion. Do you remember when Dr. Berryhill talked about serous otitis media versus purulent otitis media? And I meant to tell you guys that too. You will notice that it says acute/chronic otitis media on your topic list. Serous otitis media falls in that as the chronic otitis media. And this is one where they don't have an infection, they just have clear fluid. So when you look at the TM, you'll just see those little bubbles, those little fluid bubbles in there, but it'll be clear. Their TM isn't red or bulging. And it's just a sign that they have eustachian tube dysfunction because their tube's not draining that fluid over and over again. So that's what this patient will come in with. They'll say, I can't hear very well out of this ear, or it's kind of feels stopped up. You look in there, you go, oh, you've got a serous otitis media, you're an adult, you don't have any other symptoms, you're not acutely infected. I'm going to give you some nasal spray to see if I can take care of that. They'll come back, it never goes away, it never goes away. They may complain of a nosebleed, they keep getting this nosebleed just on this one side. If it advances farther, they'll come in and now they have double vision because it's affecting their cranial nerve 3. They may notice a neck mass, again, it's that lymphadenopathy, it's non-painful, and kind of a nasally speech. So make sure you know this one, all right? This is one I do not want you to miss. We probably had 3 or 4 patients. Every one of them was male, every one of them was Asian descent. And every one of them started with a chronic serous otitis media that didn't go away. Okay, and this is why. Don't tell Larry what we talked about. This is why. So I love this picture because it shows you exactly why they get that serous otitis media over and over again. Here's the tumor. So this is the septum side of their nose. This is the outside over here. This is where their ear would be on the outside of their head. This is the eustachian tube opening right at the back of the nose where it comes down. And you can imagine how this tumor doesn't have to get much bigger before it starts blocking this opening. If it was moved over here just a little bit, it would already be blocking that opening. So they can't drain the fluid out of that middle ear. This is what it will look like on a PET scan. Okay, so PET scans are the greatest things ever. They're super cool to look at. I guess they're not the greatest thing ever because if you're getting one, that means you've got cancer. So we'll disregard that part for a second and look at it as how cool it is from a provider point of view. So how they work is the patient is injected with a glucose type uptake, and what will happen is that any place in your body that's really metabolically active, like the cells are turning over very quickly, will take up a whole bunch of that glucose because that's what it's starving for, right? It needs lots and lots of energy to run that metabolic overturn. So we do this, we take a scan of your entire body, and any area that lights up really bright is an area where there's tumor, with some exceptions. Because you will notice his entire brain is lit up. Surely his entire brain isn't eaten up with tumor, right? Why would his brain light up on this scan?
Because oxygen is going up there.
Okay? Right, and it uses a lot of glucose. It's really highly metabolically active. So the brain will always light up every time you do a PET scan, which means it's not a great imaging scan to look for any kind of brain tumor. You have to do an MRI for that. PET scan will never show you. But it will show you in great detail exactly where this nasopharyngeal tumor is. Because you can imagine trying to look at this on a CT or an MRI. There's so many little structures going on right here in the head and neck, it's going to be hard to differentiate what is what. But with this, it just lights up really bright, shows you where it is. It's also great because it will show you where you have distant metastases. It'll show you, oh, you've also got a lymph node here, and you've got a lymph node there, and it's gone to your spine, lots of different places. Okay, so nasopharyngeal carcinoma. The treatment for that is surgery, radiation. Again, you can imagine the surgery isn't awesome if you think of all the things we have to take out of there. A lot of times we'll do radiation first to see if we can shrink it down and not have to take as much good tissue as we would have had to before. Okay, sinus malignancy. Most commonly in the maxillary sinuses. I've never heard of a sinus malignancy in the frontal, although I don't know why it couldn't go there. I guess it could. The most common one, obviously, is squamous cell in the maxillary sinus. What else do we need to know about this? Oh, these can get really nasty really quickly because they don't always stay in the maxillary sinus, and they can also eat through bone. So think about where your maxillary sinus is, where the bottom part is, and where the top bone is. If the cancer decides to go upstairs, then it eats through your orbital rim, into your eyeball, back into your brain. If it goes downward, it eats into your palate, takes care of all of that. It can go lots of places and it can get really bad. Can metastasize distantly as well. So you can get it to your lymph nodes in the neck, you can get it in the brain, you can get lots of different places. Chronic sinus infections, we think may or may not lead to maxillary sinus cancer. I think that's kind of pushing it, but it can happen. Asbestos, sawdust, chemicals, so anything that you inhale, any chemicals you inhale can also go to the sinuses. Okay, pictures are going to be gross in a minute, just to warn you. You may have already seen it. Not yet, though. I'm building up tension. Okay, so signs and symptoms. Similar to chronic sinusitis. Well, thanks. Awesome. So I've missed like 100 sinus cancers. Great. Which often delays the diagnosis. So they come in and they go, oh, I just have so much pressure here and kind of have a headache going on. And okay, I think you probably have a sinusitis. Let's treat you with an antibiotic. They come back, well, it's really not better yet. Okay, well, maybe we need a different antibiotic. Let's try something different. We do something else. Maybe you need a nasal rinse. Maybe you need all this other stuff. And we delay it further and further down the line. So don't delay it. If they don't get better after their antibiotic treatment, at the very least, get an x-ray, which we're going to talk about tomorrow. And then once you see something crazy on x-ray, you're going to get a CT scan. Go from there.
It'd be more like unilateral and sinusitis would be in both?
Yes, it very well can be. Now keep in mind you can have a unilateral sinusitis as well, or maybe a bilateral sinusitis, but they only really feel pressure in one side. So a unilateral sinusitis is not that terribly uncommon. So CT scan is the way to diagnose this because we want to see if there's been any bony erosion, if it's eaten through anything. Treatment, surgery, and then radiation and chemo afterwards.
Does it say epistaxis? Is it anterior or posterior?
Probably, we won't be able to tell because it's probably the tumor that's bleeding out. And so it'll be coming out of the maxillary sinus and we won't know one way or the other. But probably more anterior. It'll look more like an anterior nosebleed because I assume it will come out instead of going back. Okay, so this is the fun you get to have if you have sinus malignancy. This gentleman had a fairly contained sinus malignancy, so all we had to do was just go in and take out the tumor, debulk the tumor, and take out this part of his palate. This young man had to have an open surgery in which we had to take out his entire maxillary sinus, but he had to keep his eyeball, yay. This guy wasn't so lucky. This is literally what it looks like in surgery. Honestly, the few times I was in surgery, I had no idea what they were doing. I couldn't tell what they were looking at, I could not identify any structures, and they're just like, oh, here's the blah, 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 nerve, here's a, take your word for it, because it was like a myth from where I am standing. So he obviously probably had metastasis to a lymph node. That's what this long suture line is down here, so they had to go open all the way down here to get all the lymph nodes out as well. They had to take his orbit, his eyeball, his cheek, and so they closed him up with a nice skin flap. This probably came from either his forearm, which is a great place to get skin for skin flaps, for the face or the inside of the mouth, or from the top of the thigh. That's probably where they got one as well.
So if they diagnosed this earlier, could they have saved his eye and...
Yes, because they could have done this maneuver to him. They could have done much less. Now, this guy who, after seeing this picture, looks like he got out easy, right? He at least only just has a hole here. But imagine, just like the cleft palate, how's he going to eat anything? Everything liquid he drinks comes right out his nose. His voice is weird because it's all nasally. And so they build things called obturators, and that's what this is. And it's almost like a denture, except it is molded to the mouth and the hole, and there's a little knob that will come up off the top of it, you can see right there, that will fit right in that hole, that defect that was made. And then they put these little parts on the side to hold on to the other teeth and hold it in. And then he can just flip that into his mouth, and now he can eat normally, his voice is more normal, and it's just more like he's wearing dentures. I saw some pretty amazing obturators, like some big ones. Patients who had all of this gone and there was just a big hole. They'd come in with this giant claw, and they put it in their mouth and they'd take it out. It was pretty incredible. These patients are interesting because you can see all of their anatomy. All the anatomy you can never see on a real patient, you can see with these patients. because it's all open, like you can see into their maxillary sinus, you can see up into everything. That's pretty cool from this point of view, from this side of the thing. Okay, so this is another young lady, and I wanted to show you this because they are making amazing prostheses now. For nose, they can rebuild noses and faces. So she obviously had a maxillary sinus. They had to take out, just like the gentleman before, they had to take out the orbit, they had to take out her orbital rim, her nose, her whole maxilla up here on this side is gone. They had to take out everything. So this is her obturator, which is top teeth. I don't know, she probably can't eat with this, I don't imagine, because there's nothing to move it up and down. It's not attached to anything to move up and down. But look at these little areas, little hook things they make here, and that's for her prosthesis to fit on. So this is to fill her out a top lip and make it look like she has teeth, and then also for something for her prosthesis to fit in. So then they made this entire prosthesis all the way around, made her a nose, the whole top lip, her face, this whole side. They gave her a glass eye, and she's almost, looks normal again. You'll notice a lot of people who have prosthesis will wear glasses because that will help keep them on. Either the prosthesis will be attached to the glasses, and this one may be to help hold it on, or it helps keep everything in place. So we had some crazy things. I had one patient who had different noses that he would wear. He had like 2 different prostheses, and they were the same color, like the same skin color, but one was slightly different than the other. It was always fun to see what nose he was wearing that day.
Are these generally covered by insurance for the patients, or are these very expensive?
They're very expensive and may or may not be covered. It kind of depends. So unlike, you know, if you have breast cancer and you have to have bilateral mastectomy, most of the time they will cover reconstruction of breast for you. But it's not always the case with things like this, head and neck, which I don't know why. And I think insurance companies are getting better. If they'll cover breast, why won't they cover a face? I would. Okay, malignant salivary tumors. The main one you need to know is mucoepidermoid. That's the most common one. It's most commonly in the parotid gland. You have probably noticed that the majority of masses and things we've talked about have been the parotid gland. There is one that we see more commonly in the submandibular gland, and that's adenoid cystic. You don't have to know all these. I would just know one. Mucoepidermoid, that's the main one I would know. Malignancy of the parotid. All are treated with complete removal of the entire gland with clear margins. Oftentimes we have to sacrifice the facial nerve because that's exactly where it sits, and so we have to take it. And then radiation afterwards. So this is a gentleman with a neoplasm. And these, you have to be really careful, because you notice on this gentleman, his face isn't terribly slender anyway, so if he came into the clinic and wasn't complaining of this, let's say he came in because he had diarrhea or something else, something not even related to the head and neck, it's really important that you notice. If you notice any kind of asymmetry in the head, then you need to ask him about it, because he may have not seen anybody for it because he doesn't think it's a big deal. But say, have you noticed that one side is a little bit bigger than the other side on your face? And then if you went to palpate, you would notice it was firmer, kind of the consistency of an eraser whenever you touched it. It would be fixed, it wouldn't be mobile, you couldn't move it around. So it's really important to bring these things up. Don't just assume that the patient has had it looked at, just because he doesn't mention it when he sees you. So here's another CT scan. Can you see the tumor? This one's a little trickier. I got smart and put an arrow on this one. So this looks exactly like the other one, pleomorphic adenoma. How do I know it's not that? What the heck can I do? Should I just guess? Yeah, I need to get an FNA, a fine needle aspiration biopsy. You got to biopsy these things. That's why you have to, because this one, it's unilateral, just like the benign pleomorphic was, only on one side, asymptomatic, just like the benign pleomorphic was. So the only way I'm going to know is I have to get an FNA of these. Oral Kaposi, oh, I'm sorry, yes.
What kind of precautions will you take with fine needle when there is when the facial nerve is intact, as far as you can tell?
That's a good question. First of all, I would send them to an actual specialist, like I wouldn't try to do it in my family practice clinic. I would probably send them to an ENT specialist. But you do have to be really careful to try to avoid the back part, right where the curve of the jaw goes around. So try to get in front of that if you can. But I would definitely send them to a specialist and not try to do it if you weren't trained to do it. But there's a chance you could hit it, and you have to tell your patient that. That's part of the consent, right, that you're gonna get whenever you go to the dental procedure clinic, and you're gonna make sure that they ask the patient about consent, you're gonna put that in your procedure note. Y'all are like, dental clinic? I don't even know what you're talking about. It's crazy. Okay, oral Kaposi sarcoma. Malignant neoplasm of the skin and mucous membranes are kind of a red-purple, dark blue looking color. Most commonly seen in men older than 60, but the thing you're really going to look for are patients who have AIDS. Sometimes you will come in, you will just notice this little, generally they don't even notice it, or it's not painful at all. They'll come in and you will notice this little purple, discolored, fleshy kind of thing standing up off the mucosa, most commonly seen in the palate. They may not even know they have AIDS. They may not even know they're sick. And then you'll notice this lesion and you'll go, have you ever been tested for AIDS, or have you had any symptoms? Do you have lots of fatigue? Are you, all these different things. So it's important to notice this for that reason. It is a malignancy, so it is a cancer that has to be treated, even if they already know they have AIDS, but they develop this. It has to be treated with surgical excision and radiation. So one thing about these to notice, this is different from the torus that we talked about, you know, those bony things that you just naturally grow in your mouth that are a normal variant. This one is on one side, whereas the torus is generally right midline. Now I tell you that, and then this picture almost looks like it's a midline, but it's more over to one side. It started over here and then it's kind of grown toward the midline. But a torus will generally be midline, and it'll look about the same on both sides. Like it'll have two little lumps on this, and they'll be symmetrical. They'll look the same on both sides. So anything that's unilateral, you have to be careful with.
This would be more tender or more bony?
It'll be more tender. It'll be kind of soft and smushy, like almost like a wart or a mole. So it'll be kind of squishy like that. Okay, laryngeal carcinoma, very closely associated with smoking, which makes sense because you're sucking in carcinogens all day long. Alcohol is considered less carcinogenic in this area, but if you put alcohol and tobacco together, oh, you got Wonder Twins activated. You're going to yourself some laryngeal cancer from that. Clinical presentation, it depends on where the tumor is. So supraglottic tumors, which is anything above the vocal cords. So when we say glottis, think vocal cord. Glottis and vocal cord are the same area. Supraglottic is anything above that, and then subglottic is anything below that. So supraglottic tumors, they're going to come in with more swallowing issues. Their voice isn't really affected yet, so they'll just come in and say, I feel like something's in the back of my throat. Every time I try to swallow, I kind of get choked a little bit, or it hurts a little bit when I swallow. If it's below that, if it's at the vocal cords or below, then they're going to talk about a hoarse voice rather than the swallowing issue. So that's how you can kind of tell. Now this is tricky, because what else can come in where they go, it kind of hurts my throat when I swallow. Everything, right? It could be strep throat, it could be GERD, it could be whatever. You could have a hoarse voice because you have nodules on your vocal cords. All kinds of crazy stuff. So how do you know it's not cancer, or should you immediately consider it's cancer? Should you jump to that conclusion and go, well, you've obviously got cancer. Let's get you to Cancer Treatment Center of America. Keep going.
If they smoke and drink together, you should probably.
Yeah, exactly. So look at their risk factors. See, do they look like the patient that we typically see gets these kind of cancers? If they don't, then you can follow it for a little while. You can try, conservative treatment. Let's try some GERD medication. Let's make sure you don't have strep throat. But don't wait more than 2 months. Maybe you can safely do it for 2 months as long as their symptoms aren't getting worse and worse and worse. And then if they're still having it, we go, okay, we've tried what we can try. Now you need to go to the ENT specialist, and they're going to look with a scope and see what's going on. This is what they'll look like, and these are right around the vocal cords. So these we have to go in and destroy the tumor, usually with cautery, or sometimes they'll surgically do it. These guys have to follow up very frequently, like every 3 months for the first year, every 6 months for the second year, and at least once a year after that forever, like for the rest of their lives. They have to come in and get the nasal laryngoscope to make sure everything's okay. These get tricky because if they are glottic or subglottic, or depending on how big they are in general, they may have to have a total laryngectomy. So we have to take the vocal cords and everything. They may have to get a trach so they breathe out of their neck forever, that kind of thing. Yes, ma'am?
Just to me, that the pinkish one looks like the papilloma.
Yeah, papillomatosis, doesn't it?
So how do you, how,
I don't know. How would I know how it was different? How would I know if it was papilloma versus this?
do you always take a biopsy of papilloma?
Yeah. Yes, yeah, that's a good point. I may not have made that clear earlier. If it's a papilloma, you gotta get a biopsy. Any growth happening in there, you gotta take a biopsy, because you don't know what it is just based on looks. Because you're right, this looks very much like that. All right, esophageal cancer, again, squamous cell, some adenocarcinomas, but most common are squamous cell. Smoking again, alcohol consumption. This one's interesting because you can have some pre-existing diseases that go untreated that can cause it, things like achalasia, which is a narrowing of the esophagus at the end. You'll learn that later when you get to GI. Barrett's esophagus, like Jamie talked about. That's a change. You get this chronic acid reflux that goes untreated, and so whenever that acid washes up into your esophagus, it slowly changes the mucosa, and it can eventually turn cancerous and just go crazy and grow all over the place. So that's why it's important to treat things like GERD. You know, a lot of times we think, well, we're just doing it so that the patient will feel better and they won't have heartburn. That's no big deal. But it can be a big deal if we don't treat it and it goes on and on. Okay, so most commonly they will present and say they have trouble swallowing. It hurts when they swallow, or they have trouble swallowing solid foods. They say, I like especially bread. Bread seems to be the worst. I just can't get that roll. Whenever I eat rolls, I can't get them down. I can drink liquids okay, but the other ones seem to get stuck right here. I just can't swallow the rest of the way down. Weight loss, they might have pain or burning. That sounds a lot like acid reflux. Hoarse voice is another thing. So diagnosis, you can do a barium study. I know you guys haven't had radiology. None of you guys have been radiated yet, so you don't know this. You haven't had radiology yet. That's where you swallow this barium liquid, and then we take images of you, and you can actually see it as it goes down your esophagus. And you can see if there's a defect, if there's any kind of anything going on in there. PET scan again, PET CT is a great thing. And then they will stage it based on different things: location and size of the tumor, adjacent tissue involvement, and nodal involvement. You don't have to know this TNM staging. I just wanted you to have heard the term at some point to know that that's how they stage cancers. And this is the same no matter where the cancer is in your body or what type of cancer it is. The terminology is sometimes different in that, you know, number of nodes or distant metastases, different things they'll use. But TNM, you'll see that staging over and over again. But don't memorize that for the test. You heard it once, now forget it. Okay, so this is his PET scan. And this is his tumor way down here in the lower esophagus. Almost looks like it in the stomach here, which is in his lower esophagus. Brain's all lit up again. Bladder here. Bladder's also one that will just light up, so that's normal. He doesn't have cancer filling his bladder. It's just one of those metabolically active areas. We had one patient who had, I don't remember, he may have had a tonsillar cancer. Anyway, it was bad. He had lots of cancer somewhere, and it had metastasized. It was like all over inside down into his neck area. So we had surgery, and then he had radiation to this area, and the skin and tissue was really thin. Unfortunately, the tumor came back, and it was wrapped around his carotid artery. So they had to